the official data of the trust, and it can be used to compare between hospitals, and it's recognized nationally and internationally by the WHOs. So what it really means is, when that patients come in, that episode, the codes capture the mortality and morbidity. It helps the managers for planning for future, such as service expansion, bed management. It makes sure that each department gets funded appropriately. It can sometimes reflect on patient safety, and the public health people use it as to monitor the frequency of disease occurrence. And like I said, it allows you to compare between one trust to the other. So just to touch briefly on the HRG codes, when each diagnosis and comorbidities and investigations get assigned a code, they kind of group together. So the more codes that episode has, the more complex the case is. And the HRG compensates for the complexity, and it compares from one department to another department. And then it just makes sure that that department is reimbursed appropriately for their services. And things like comorbidities can influence the HRG codes. So if you just imagine a patient that comes in with an asthma exacerbation and he has a background of type 1 diabetes, surely this patient doesn't just get asthma treatment. They'll need nurses to monitor the sugars. They need 4-hourly BMs. And the HRG codes, if you do put comorbidities on your discharge letters, the HRG codes will automatically assume that this patient needed more nursing time than a patient that has no comorbidities and just comes in for asthma treatment. So I'll show you a couple of examples in a bit later. So you'll probably be thinking, why do I still need to know about all this? Well, the thing is, junior doctors does most of the writing. You write majority of the TTOs, you go on ward round and the consultant says something and you write. And therefore, your role in information governance and good record keeping is actually greater than you think. The coders are not clinicians. They can't assume. They don't have medical knowledge. They just learn to code. So they try and do it based on case-by-case basis. But most of the time, because they have a actual deadline to finish a coding, they have to do it off your discharge letters. So they've got access to ICM, ICE, and all the internet systems, but not all the time they actually get the patient's case notes. So therefore, whatever you put on a discharge letter is what they're going to go by. And let's forget about the money side. If you go on to want to do research audits, any studies, statistical analysis, especially those of you who do it retrospectively, this is where you get your clinical data pool. You ask the audit team, can you show me the number of patients that come in with UTI in the last month? And that's where they get your data from. They pull out every case that's been coded with UTI and they give it to you. So if it's been coded in error, you might miss some. If it's been also coded in error, you might get some patients that it's not a UTI, but they get labeled as UTI, so that will, throw your sample size. So here's a bit of an example to show how comorbidities influences the tariff. A 2-day stay for carcinoma prostate with no comorbidities, it's £1,421. But if you add oral thrush, it goes up to £3,591. I don't know why it goes up by 2,000. The only reason I can think of is nystatin is a 4 times a day dose and they need mouth care, so the HRG compensates for extra nursing hours. Similarly, for a 5-day stay for carcinoma tongue, it's £1,387, but if you put urinary incontinence, it's £4,697. Now, there are a lot of urinary incontinent people at the LRI, and these are the small details that the nurses picks them up, but as doctors, we don't really see them as something that needs to go into a TTO, and it often gets missed. And that's how much your department are getting paid less. So every bit of detail is important. If you're going to go away and forget the whole lecture, I would ask if you can just remember this one slide. I'll show you a couple of examples of how it works, but I'm sure you come across a lot of case notes that we see a lot of question marks around. Even by the end of the episode, when the patient gets discharged, it's still query pyelonephritis or query prostate cancer. And the coders have a strict rule. They cannot code these few words. So if if for some reason on the actual note it's still query, 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 and on your diagnosis, your discharge letter, it's also a question mark, or use any of these words, they can't code it. So they'll code it based on symptoms, and I'll show you a few examples, but it's completely inaccurate. So a lot of the times you don't want to commit to one diagnosis. So you can use words like probable UTI or presumed meningococcal septicemia. You don't have to say, I know it means exactly the same, most likely possible, but because the coders, in the coder world, this is set in stone and it's been used internationally, so we have to work around them. So this is quite useful for you to remember when you're doing discharge letters. So this is an example. I got all these examples from the Peds ward. Child comes in with constant intermittent crying, passing pellets for the last 2 weeks, so query constipation. If you look at the information they gave to parents, they actually are treating it as a constipation episode. Unfortunately, they can't code that question mark, so they put it as constant intermittent crying. That's your database. So if you're doing a research on constipation, you won't pick this patient up. But if you're looking at how many patients comes in with constant crying, you'll get this one. And that's £56 less your department gets. And obviously, from clinical governance point of view, this is completely wrong. So looking at the next one. Now, this is quite well written, actually. It has a lot of details, but it's not a diagnosis. Diagnosis is not in paragraphs. If you read, this patient came in with high blood sugars, ketones, background of type 1 diabetes, is acidotic on admission. This is DKA until proven otherwise. But because nowhere in the discharge letter says DKA, and coders are not clinicians, they know what you're thinking of, but they physically can't code it because they just cannot assume that this is DKA. So it gets coded as type 1 diabetes. And it's £68 less if you actually code them as DKA. And it's from an accuracy point of view, plenty of patients have type 1 diabetes, but they don't always end up in hospital. It's only when they get DKA or some complication that they come in with. The next one is difficulty in breathing and likely due to viral ERT. They can't code likely. Felt to be due to a viral infection, which they also can't do that. So it gets coded as difficulty in breathing and reduced feeds. The one thing I need to highlight here is using the abbreviation of DIB. While that's okay and most people know what it means, the coders, they're not clinicians. So in cardiology, MS is mitral stenosis. In neurology, MS is multiple sclerosis. And just because the patient comes from a cardiology ward, the coders can't assume that MS means mitral stenosis. You can get a multiple sclerosis patient coming in with heart problems, so they won't code it. Even if you do put MS, they have to look for evidence in the notes, so it's just making their life miserable. But the example here is if you actually take the likely off and put either presume or probable or treat it as, it gets coded properly as viral ERT, and you get £114 more. This one, the question mark ones, there's query seizures under investigations, and suspected seizures. They can't do that, so it gets this episode that your child comes in with is called a normal movement in terms of the trust data, and that's £117 less. This is similar, atonic seizure, query atonic seizure, nowhere, possible atonic seizure, they can't code either of that. It needs to be changed to probable or treated as. So therefore they just code it on the next thing that they can code, which is floppy, unresponsive, incontinent drooling, and it's nowhere near accurate, and it's also £117 less. Likely asthma, and nowhere else says otherwise. So they still can't code the word likely, so it goes on as DIB and wheeze, and that's 300 difference if the consultant actually do diagnose as asthma, that's how much the department actually lost, and there are plenty of asthmatic children around. This one is one of my last examples, but we see that all the time. This patient came in with frontal headaches, drowsiness, vomiting, loose stools, has a high fever, non-blanching petechiae, we suspect meningitis. So we do everything. We investigate, we take blood cultures, we start on IV antibiotics. In adults, they also start on IV acyclovir until the cultures and lumbar punctures prove negative. So we do that all the time. And in this patient, the cultures are negative, so the diagnosis is most likely it's viral infection. But because the department has already used the resources on treating the patient for meningitis, technically if the blood cultures were positive, you still won't really change your management. You've already started on empirical antibiotics. So the main diagnosis that they can code would be viral infection, but if you just remove that query and say for presumed meningitis, they can add it on as a second diagnosis, and that gives you £534 more, simply because you've already used the resources and you need to get reimbursed back for whatever you've spent on this patient. So to translate that into numbers and figures, the 7 examples I show you total up to £1,359. Imagine a number of patients that get discharged from our services. Let's just estimate 7 errors per day, 1 from each pediatric ward. That's £38,000 a month. And it's not difficult to find 7 errors in the whole hospital. And that money alone is enough to pay for an FY1's salary for a year. You can do a lot of things with that. You can employ a doctor to just sit down and write discharge letters. So no wonder the NHS is a bit bankrupt. So it's just for you to be aware that you have huge implications on funding. We don't really get told much about how much the department's getting, but it's just for you to be aware that that's how they get paid. So I was on my geriatric posting in the last rotation, and I came across this gentleman. Just a bit of the family background is this daughter has a disabled husband. She lives on carer's allowances, and she saved up enough to fly her dad from India for a visit. On the 2nd week of holiday, he had a stroke, somewhere down in York, I think. So it's a right-sided hemiplegia, swallowing difficulties, doubly incontinent. He was bedbound. He keeps getting recurrent aspiration pneumonia and hospital-acquired pneumonia, so he was quite medically unstable. So he spent 2 weeks in the stroke unit, and then he stayed for 2 months in the geriatric ward. He has no travel insurance and no health insurance. He couldn't speak much English, and he's not covered by the NHS because it's a visitor. So what happens with this patient is the ward clerk faithfully every day will take the case notes to the coder's office to get that day's events coded. Every single entry in the notes gets coded. Your lab test, imaging, food space, bed space, nursing care, physio, OT, speech and language, they all get accounted for. And even things like the consultant coming on the ward round, and as juniors we write ward round by Dr. So-and-so consultant, patient stable, medically stable, continue plan, less than 10 words. It's a different price from when a registrar says that, or when, as FY1, you do your own ward round and says that. So it came up to close to £100,000, if not more, and the daughter was just desperate. She wanted to move the father home to India because she can't afford it, but because of his condition, he won't survive the transport, let alone having a long-haul flight. So they just simply couldn't afford the bill. So it's a bit of a food for thought. It's not cheap, healthcare. Let's not take the NHS for granted. Medicine is not all about money, but we somehow need some kind of funding from somewhere to maintain the healthcare services that we provide. So how do we improve? Just remember the do's and don'ts table. As junior doctors, we really do most of the writing. So we have a huge impact on clinical coding. So when you're on call and you get this nurse coming to say, oh, it's a weekend and the consultant says he can go home, please do the TTO, you have no idea what this patient is all about. Please take an extra 5 minutes to go through the notes and find out why they're here and what the final diagnosis is. You will do at least 1 or 2 of it when you're on call anyway. So be as thorough as you can. Legible handwriting in the case notes are very important because they do go through your case notes. And please avoid using the question mark. just try and remember that the patient actually gets the discharge letter at some point. And if they spend 3 months in hospital and they go home seeing that your diagnosis is still a question mark, it's a bit dodgy. They'll start wondering whether the doctors and the team actually know what they're doing. And it's just not nice and professional. The question mark is okay when you're requesting tests and to rule out things, but don't put it in your final discharge letter. So this is the do and don'ts slide again for you to remember. I think I have got, yeah. That's the end of the lecture. Thank you very much. Are there any questions? If you can do the post-lecture survey, that'd be great. Thank you.